Hi, and welcome to today's episode of ObGynugget. This is a segment in which we give you a substantial bit of information in a brief period of time. The topic for today is something that troubled me not only as an undergraduate student but even as an OBGYN resident. The understanding of this topic is something that requires quite intricate knowledge of the anatomy of the pelvis and the supports of the uterus, and also the surgeries need an approach because this is something that is not given in any of the textbooks that I have read. It was given in a few Indian authored textbooks like Datta and Shaw, but in my post graduation, there were not too many books, especially the foreign authors, which do not mention of most of the surgeries that are done for this topic. And the topic is going to be prolapse or pelvic organ prolapse in young women. Now, why is this significant? I would say the reason being a lot of women are nutritionally deprived and are anemics. This leads to a very poor blood supply to the perineum. Apart from that, there is the parity of our women is quite high, and because of this, because of multiple vaginal deliveries, your pelvic ligaments, all the supports of the uterus and the vagina, weaken up quite a lot because of the anemia as well as increasing parity. So we often get women, almost of all the total patients who come to us with prolapse, almost 10% of the patients are the ones who are below the age of 40 and even below the age of 30, who probably even wish to have a kid in future and for whom hysterectomy is just not an option. So this lecture is going to be for the treatment and management of these women who are presenting to our OPDs with pelvic organ prolapse. So for basics, we have something called as Delancey's classification. So this Delancey's classification was given to mention about the three levels of supports that a uterus and vagina has. So of it, the first support is the uterosacral and the cardinal ligament complex that is there. This is the support that attaches the uterus to the sacrum and to the lateral pelvic walls. Apart from that, the second level of support is formed by the endopelvic connective tissue. This is the connective tissue that surrounds all the pelvic organs and attaches them to the lateral pelvic walls, and it keeps them in their place. Now, where do you see this connective tissue? You would see this especially when you're dissecting the bladder downwards during a cesarean section or while doing a total abdominal hysterectomy, or when you're doing a vaginal hysterectomy followed by an anterior colporrhaphy. You often dissect those fibers and bring them towards the bladder so that the bladder can be reposited backwards from its prolapsed location. So those white fibers that you see are the fibers of the endopelvic connective tissue. They invest or they are surrounding your entirety of cervix, your vagina, and your lower segment of the uterus, the isthmus of the uterus, and attach it to the lateral pelvic walls. Apart from that, your third level of support is formed by the levator ani with the perineal muscles and the perineal body. Now, a combination of all three of these, especially the first level of support, is what causes the descent or the prolapse of the uterus and the cervix that occurs in these women. Now, there is another reason as well. There is another factor that leads to women who are not even who have not even have had any kids and are nulliparous for them to have prolapse. So, in a female who is nulliparous and for her to have prolapse, she probably has some connective tissue disorder because of which this endopelvic connective tissue as well as the connective tissue in the cervix, the collagen that is present in the cervix loosens up, and these women end up having elongated cervix. So either it can be in the prolapse can be in the form of an elongated cervix, or it can be in the form of the entire uterus and cervix that have descended down because of the lack of support from the level 1 support. Another theory that speaks about cervical elongation is that if you are going to divide the uterosacral ligament into two halves, the upper and the lower half, because of multiple vaginal deliveries, the lower half of the uterosacral ligaments keeps on getting pulled and it weakens up, whereas the upper segment, the upper half of the uterosacral ligaments stays intact. Now, because of this, the uterus is kept in its place, but the cervix, which has the lower half of the fibers of uterosacral ligaments, उसके weakness की वजह से the cervix starts elongating. So women with multiple vaginal deliveries can have cervical elongation because of this hypothesis. So when I talk about the surgeries that can be done for these young patients, now we have to remember that these are patients in whom hysterectomy is not an option, probably because they wish to preserve the uterus for further childbearing, or they just don't want to get it removed at this age, or because of one fact that you should remember that after doing any sort of hysterectomy, even if you're leaving the ovaries behind, studies have shown that those ovaries are devoid of any blood supply 5 to 6 years down the line, even if you're sparing the ovaries. So a female will have surgical menopause within 4 to 5 years of surgery, even if you have not removed the ovaries, and you wouldn't want that to happen to a 35 or 40-year-old female. So these surgeries are the ones that are made to ensure that the uterus is preserved and is not removed, unlike in the elder patients in whom we remove the entire uterus. So we have two types of surgeries. One is for the entire descent of the uterus as well as the cervix, which we call as the sling surgeries. And the other one is the cervical amputation that we do classically for cervical elongation. I'll begin with the cervical amputation part, the cervical amputation surgeries, because it's a shorter segment. It involves a Manchester Fothergill repair, and the second surgery is Shirodkar's modification. In this, the elongated cervix is cut off. The uterosacral ligaments are advanced. By advancement, I mean they are attached at a much higher location, and that elongated cervix, the cervix which ideally should have been, let's say, this long, let us assume this was a normal cervix and this was a vagina. In these women, this cervix elongates to a great extent, and hence it comes out from the vagina. If this is the vagina, so all you need to do is you have to transect this cervix and then reposit the uterosacral ligaments on a higher location. So in this, you end up pushing the cervix that had come outside upwards. Whereas in Sling surgeries, the entire uterus has come down. So in this, you tend to ensure that the ligaments that were weakened, namely the uterosacral and cardinal ligaments that were present in the level 1 support, they are strengthened by these surgeries. So the advantage of doing sling surgeries is that you use a foreign body, you use a synthetic material to do these surgeries. Whereas in cervical amputation and in the earlier traditional surgeries, you used to use the body's own tissue, something like rectus fascia, rectus sheath fascia, or even using the native endoconnective tissue. In this, whenever there would have been a lack of the endopelvic connective tissue or the rectus sheath would fall inadequate, we could do nothing about it. Plus, there used to be reversal, there used to be relapse of the prolapse in this. Whereas in sling surgeries, because we are using a synthetic material, there is no chance of recurrence. So to talk about all these sling surgeries, which are not mentioned in most of the books we'll read, there is a classification that I prefer to follow. This is a classification that has been unofficially given by Dr. Virkud, Dr. Ajit Virkud, who's a brilliant gynecologist from Mumbai. In this, he says that whichever sling you're doing can be classified into three categories. The first one is the direction in which the sling is done. The second one is the type of sling it is, and the third one is the loop that it forms. What do we mean by this? We learn as we see the surgeries. So the first surgery that was designed by Dr. Shirodkar in the 1950s. This was a posterior sling which was static and it formed a closed loop. What does this mean? Now, if you see, this is a cross section of the pelvis where you can see over here there is the rectus muscle. Over here there is the rectus muscle. Over here you can see this is the uterus. This is a cross section. So if this was your person, if this was your female, they have taken a cross section at this level. At this level, they have taken a cross section, and this is the cross section that you're seeing over here. So this is the rectus muscle. Here is your uterus, and here you can see the sacral promontory. The sacral promontory is basically a part of your hip bone that you can see. Over here, you can see the sigmoid colon, which is present on the left side. You're looking at it. Remember, you're looking at it from down to upward. So this is your left side, whereas this is your right side. So the sigmoid colon is obviously present on the left side. Here you can see that there is the psoas muscle as well. Now what you can see, these dotted lines are the slings that have been used. We use a Mercilin tape for this surgery. In this, the uterus, Shirodkar primarily decided that he will take a stitch on the posterior side of the lower segment of the uterus or the isthmus of the uterus. As you can see over here, he has taken a stitch over here, and then through the leaves of the broad ligament, these are the leaves of the broad ligament, he took it backwards, then he took it to the psoas muscle. He did a psoas hitch. Basically, he attached the suture material to the psoas muscle, and then by bypassing the sigmoid colon, because sigmoid colon is a part of your colon. You do not want a foreign body in contact with your colon, otherwise it might erode into the cervix and there will be a fistula that is formed and that will lead to fecal accumulation in the peritoneum. So he decided that he has to somehow escape it, and this is how he just decided to take it slightly farther away from the sigmoid colon. Finally, he came to the sacral promontory, and on the anterior longitudinal ligament which is present on the spine anteriorly, which continues on the sacral promontory and the sacrum as well, he decided to take another knot. So this was obviously a posterior sided, because this loop is being formed in the posterior side. It was a closed loop. You can see that there is no open end to it. It is a continuous closed loop, and it was static. Why static? Because it was attached to a bone. So whenever a patient would cough, there was no scope for this tape to get loosened up. So it can often so happen that if you have done that loop so tightly, your bowel loops, your sigmoid colon, your large intestine, all of them can get entrapped and strangulated inside this closed loop. So this was a complication. The advantage though of it was that your uterus was being maintained in an anti-flex direction. Now, if you remember that your uterus, if you're seeing it from sideways, is usually like this. So basically, if this is your anterior and this is your posterior, your uterus is often in the direction of anti-flexion and anti-version. So when you would do this surgery, this would get pulled in posterior direction and it would ensure that the anatomical anti-flexion was maintained for this uterus. This surgery was quite successful, but the problems were that it was a very skilled surgery. It was very difficult to do that psoas muscle hitch, which is something that gynecologists are not used to. It was very difficult to avoid the sigmoid colon and injure and to avoid injuring it. So Purandare, Dr. Purandare, in the 1960s and 70s, he said that let me modify it a bit. We are more comfortable doing cesarean sections. Cesarean sections, we do it anteriorly. So let us form an anterior sling surgery with the tissue that we are very comfortable in handling. So he said that I'll make an anterior sling. I'll make it a dynamic sling so that whenever the patient coughs or whenever there is an increase in the abdominal pressure, that won't stay static. It can open and it can close. Basically, the diameter of it can increase. But yet it was a closed one. So he decided that instead of doing posteriorly, I'll take a stitch on the anterior side, on the isthmus of the cervix, following which he took it right again from the broad ligaments and brought it anteriorly and attached it to the rectus sheath or the rectus fascia of the rectus muscle. Now we are very comfortable in opening the rectus sheath, we are comfortable in opening the rectus muscle, and hence this was an easy surgery for all the surgeons to do. But a major problem of this were two. First of all, that it was an anterior thing that was done. So this anterior segment which was taken on the isthmus of the uterus, whenever a female will become pregnant, the point of doing these sling surgeries is that a female wishes to conceive in future. So whenever she would do these surgeries and a female would conceive and she would deliver by cesarean section, this muslin tape would get incised while doing that surgery because it was placed on that isthmus, which eventually becomes a lower segment, and you take the incision on the uterus on the lower segment. So this will lead to failure of the surgery and recurrence of prolapse after pregnancy. Apart from that, on the anterior wall, whenever this sheath was attached completely, it would again lead to failure while opening the rectus sheath. So this was being seen that not only the failure during a cesarean section, but also that it was disturbing the anatomy. As you could see in the previous surgery in Shirodkar, the uterus was being pulled posteriorly and the angle of anti-flexion that was behind. If this was your anterior and this was your posterior, this was in Shirodkar, it was being ensured that this is kept this way. But in this, there was an anterior pull that was given towards the rectus sheath, and because of which there would be a displacement of a normal anatomically anti-flexed uterus, making it retroflexed. This retroflexion would also lead to detachment of the posterior connective tissue, leading to the rise of enterocele posteriorly. Because posterior से वो दूर जा रहा है, the uterus is being pulled anteriorly, so that posterior space that has been created would lead to the formation of the denonvillous fascia posteriorly would get separated. So this would lead to the pouch of Douglas coming downwards and bowel coming through it. So this would increase the risk of having an enterocele. So Virkud was a surgeon who decided that I understand that Shirodkar has complications of expertise, whereas Purandare has complications of anatomy. So he decided that I will combine the two surgeries and I will make a composite. Composite is a mixture of both the slings and it would have advantages of both of them and negate the disadvantages. So he said I'll make an anterior plus posterior sling. wherein he decided that on the side where there was sigmoid colon, he will not go posteriorly. He would instead go anteriorly, and on the other side, he would go posteriorly. It would be a static and dynamic sling. Why static and dynamic? Because one end was attached to the sacral promontory, whereas the other one was attached to the rectus sheath, and it would be an open sling, so there was no risk of entrapment. He also said the stitch would be taken posteriorly so that whenever this female has a cesarean section, she will not need to have her tape incised anteriorly. So there was no incision on the tape anteriorly, and the tape wouldn't open up during surgery, and there would be no failure of the surgery. This is a surgery of amazing relevance, and it is done today, and it has excellent success rates. Although in all the teaching institutes, Purandare being the easiest one, what we call as a Purandare cervicopexy. Cervico, because it is done on the level of isthmus and cervix. Pexy is repair. It is done more commonly because of its much more ease of doing, but an ideal surgery would be Virkud. These were the three major surgeries that were being done. There were three other surgeries as well that you need to know, which is very good to know and which is amazing if you're able to tell it in your exams. The other three surgeries were, one was Khanna sling. So in Khanna sling, I would like to show it on this diagram itself. He said that I will attach it to the uterus in the center, and my sling will go and attach to the anterior superior iliac spine of the iliac bone, जो दोनों साइड का ASIS है. He said I would attach it there. So it became a lateral sling rather than an anterior or posterior. It was an open sling, obviously, and it was a static sling because it was attached to the bone. The only problem of this was if this tape would get infected, it would lead to periostasis of that iliac bone. But this was a surgery that Dr. Khanna designed in the 1980s. Apart from that, Soonawala said, Soonawala was a surgeon who worked in Wadia Hospital in Mumbai. He said that I can do a modification in which I will do Shirodkar surgery, but I will make it unilateral. He said that I will only do the right side of, he said I will only do the right side of the surgery. So he said that I will only do it on this side, so it will be, although it will be a closed loop, but it will be unilateral and it will not impede upon the sigmoid colon or the psoas muscle. So it was very similar to Shirodkar. Shirodkar has an S, Soonawala has an S. Both of them are posterior slings. One is unilateral, whereas Shirodkar is bilateral. Apart from that, a last surgery was Joshi's sling surgery. In Joshi's sling surgery, he said that I will do the same surgery what Purandare did, but I would, instead of attaching it to the rectus fascia, I would attach it to the ligament of Cooper or the pectineal ligament that is present in the pelvis. So again, it was an anterior loop, but it was being attached to a ligament that does not have much tensile strength. It is something that is static. So it became a static surgery, and again, it was a closed loop. So these were the six major sling surgeries that have been designed, all of them by Indians, wherein we can do those surgeries using a synthetic material, and we can prevent this uterus from being removed. There are further more surgeries that are given in your books, which foreign authors have devised, in which we do hystropexy. In hystropexy, we take the fundus of the uterus and we attach it to the sacral promontory using a mesh. These are surgeries that we don't really do because use of mesh in prolapse, in uterine prolapse, is a FDA's approval stage 3, which indicates that the mesh is not that safe to be used for correction of prolapse. It can only be used in the correction of urinary incontinence in SUI, but not for correction of prolapse as much as possible. So these are the surgeries that you'll need to know for your exams for correction of prolapse in a young patient. We started off by talking about cervical amputation, in which there is Manchester Fothergill repair with Shirodkar's modification, and then we spoke of all the six other sling surgeries. I hope you understood this in this brief lecture. I'll be taking a much more detailed lecture on urogynecology in a regular app segment. So please do subscribe to us for more lectures, and I'll see you in the next OBGYN Nugget. Thank you.